Thank you for all making the time to be here. The voice you're hearing, hopefully, if my connection's still going strong, is I'm Anna Chodos. So I'm the executive director of Dementia Care Aware, who's partnered with the Institute for Healthcare Improvement and Lifelong Medical Care for this session today. And we're just really glad you're here. We feel like it'll be really engaging, informative, and hopefully customizable to your questions. So please get those ready. Just want to introduce the focus for today, which is Dementia Care Aware, which is an early detection focused primary care support organization to help folks do early detection and screening of dementia, and age-friendly recognition and how those two can go together. And we have an FQHC case study with Dr. Michael Goldrich, who's the specialty medical director at geriatrics at Lifelong Medical Care. So he's going to talk about their experience. And we're going to start with Kelly McCutcheon-Adams at the Institute of Healthcare Improvement and Nicole Korb, who's also at IHI. And if you've done anything with IHI around age-friendly care, you've seen them many times present the amazing work and the way that they're supporting us all achieve recognition. So really briefly, we are offering continuing education credits, and we're very lucky to do so through Partners for Advancing Clinical Education. So just want to make sure you saw their information. And we can provide it again if you have any questions, but they're our CE/CME provider. We have a brief opportunity to share with you some financial disclosures. I'm the only one here, so I have a brief disclosure here. I'll put it out here, but no one else has any disclosures today. Just want to let you know that throughout we'll be monitoring the chat, the Q&A, whatever works better for you, and we put the material on Dementia Care Aware within a day or two of every webinar and every session. So look forward to having that available to you after this session. We don't, and the slides too should be available if you want to reference those. And let's see here. The other thing I always encourage people is just to consider getting your questions ready, as I said, because knowing what you were hoping to get out of this always helps you ask great questions as we're going through. And at the end, again, we should have plenty of time. All right, so you're probably seeing in the Zoom Hollywood Squares edition some of the faces that have their cameras turned on. I'm the one speaking here all the way to the left, Anna Chodos. We have Dr. Goldrich, who I already mentioned his title, but do you want to just say hi really quick, Michael?
Oh, hi, everyone. Yeah, my name's Michael. I work at Lifelong Geriatrician, and Lifelong's in the Bay Area, San Francisco Bay Area, Berkeley.
We are neighbors. Wonderful. And I'm going to pass it over to Kelly to just say hello as another one of our other presenters.
Sure. Thank you, Dr. Chodos. Kelly McCutcheon-Adams from the Institute for Healthcare Improvement. Delighted to be with you this afternoon. And I'll just quickly mention you all are the start of my vacation. Great way to close out. After Nicole and I speak, I will be transitioning to phone, but I'll still be here and available. Thank you.
Thank you. We feel honored to be part of your vacation. And Nicole, you want to say hello? Thank you for being here.
All right. Hi, everyone. My name is Nicole Korb. I'm a project manager at IHI, and it's so lovely to see some of you. And please let us know if you have any questions during your presentation later.
Yes. So let's go over, thank you so much. So let's briefly go over the learning objectives. So after this session, you should be able to describe the role of the mentation 4M within the framework and its relevance to dementia screening in ambulatory care settings. Explain how the age-friendly health system recognition can serve as a foundation for implementation of cognitive health in primary care, and apply implementation strategies for integrating structured dementia screening in an age-friendly clinical setting. Don't know how many of you are engaged in this. I hope many. You'll hear from Michael's experience as well, kind of some of the key elements there. And I feel like this is hard work. So that we're a community here learning about how to do this together. So I'm going to pass it over to Kelly and Nicole to present first, and they'll also have some time for questions right after their part of their presentation and talking about the work we're doing.
Well, thank you. So delighted to be here today, and our connection with Dementia Care Aware has been really just such a strong feature of our age-friendly work over the last few months. So delighted to be here today and grateful to Dr. Chodos and Dana for joining us last week at our virtual convening. Nicole and I are really glad to be here with you today. And I realize this will be known to some of you, but we want to make sure everyone's singing from the same hymnal, as it were. So next slide, please. So age-friendly work is a movement. It has many, many different components and avenues to it. And the focus of the movement is that all care with older adults is age-friendly care. And that means guided by an essential set of evidence-based practices. This work goes back over 10 years. There was a very specific process of reviewing evidence and convening experts to center in on the 4Ms. It's care that causes no harms, and it's care that is consistent with what matters to the older adult and their family. Next slide, please. Through that process of sifting through all of that evidence, this is the framework that emerged, what are colloquially called the 4Ms of age-friendly care. And I just want to pause here and acknowledge that all the age-friendly work is an initiative of the John A. Hartford Foundation with IHI, and also the American Hospital Association, the Catholic Health Association. And we're just so grateful for the support of the John A. Hartford Foundation to make this work a reality. So the 4Ms of age-friendly care are what matters, medication, mentation, and mobility. And these are, of course, incredibly interwoven. And I have found, even in my own personal life, I'm currently more and more by the day a caregiver for an 89-year-old neighbor. And I just find that this is such a logical, thoughtful way to structure thinking about how to align what matters to him with key issues of medication, mentation, and mobility. So even at a recent appointment with his new primary care physician, I found myself saying, I think it's important for you to know that what matters to Al is to be able to stay in his home where he lived with his wife prior to her death. And here are some other things to think about. So it's just a really useful framework in all settings. While we're waiting, I'll just say key feature to note in the mentation, which is obviously a focus of today's conversation, is that mentation refers to depression, delirium, and dementia. And so cognizance about dementia, delirium, and depression is a really important part of understanding the mentation M. And the age-friendly work started in hospitals and has evolved in ambulatory care settings, home health settings. I'm helping finish up some prototyping in hospice, which of course has some very distinct features. So lots of work, lots of different settings, and just a wealth of resources available on our website. Thinking, Nicole, maybe you could pop our website on so people can access those free resources. So why the 4Ms before I turn things over to Nicole? They represent core health issues for older adults. Again, they build on that strong evidence base, and they simplify and reduce implementation and measurement burden on systems while increasing effect. These are so interconnected, synergistic, and reinforcing of each other. And Nicole has put in the chat our website, just a wealth of free resources, guides for different settings, care descriptions, which Nicole will talk about. So I'm going to turn things over to Nicole, who is our all things recognition in terms of the process of becoming age-friendly recognized. Thank you, Nicole.
Thank you, Kelly. Yes. So, like Kelly was saying, this is a robust and very just meaningful work framework that we as we work more in the 4Ms and the age-friendly space, it just becomes more and more meaningful, and we realize that it really does affect all older adults and all adults and everyone, right? Because it's not just the older adult that's receiving the care, it's their caretakers and their families and their children. So we can go on to the next slide. I put the link to our website in the chat here, and these are just a few of the resources that we have available to all of you free of charge. We are funded by the John A. Hartford Foundation, and because of their funding, all of the resources and all of Kelly and I specifically work with our action community, and that's free. We want to make this accessible to all of you. And we do not gatekeep any of our resources. So you'll see here that we have specific guides to implementing the 4Ms in the different care settings. And like Kelly mentioned, we're working on some guidance for specifically hospice as well, an addendum. And so if you visit our website, you'll see that all of these resources and so much more. You go to the next slide. And talking a little bit more about what recognition is, there are two levels of recognition. So the first level is we have a care description form. So all those guides are a resource to help you to fill out the care description form that outlines all 4 of the M's and all of the requirements that your care setting needs to fulfill in order to become an age-friendly participant. And so this is just submitting your plan of how you will assess, document, and act on all 4 of the M's to us. You submit them to IHI, and we review it, and then we get back to you about maybe whether you are accepted right away, or maybe you might have to fix a few things in your care description form. We will work with you on that. And then once you are submitted for participant, after 3 months, you are eligible to submit for Committed to Care Excellence, which is our level 2, and that deals more with submitting the counts of older adults over the course of 3 months that have received all 4 M's. And so this deals more with like measurement and data, but it really is just as simple as submitting to us the number of older adults by month for 3 months that have achieved or that have received all 4 M's. And I think sometimes people or teams get a bit overwhelmed and think, wow, we have to submit all this. We have to have everything perfect. But that's not the case, especially with the participant level. We really do encourage you and want to remind you that this is just a plan. We know that plans change. We work in an improvement organization, and so we know that nothing is ever perfect the first time, nor will it ever be perfect. And so we just want to encourage you and want to let you know that both Kelly and I are here to support you, not only today, but also moving forward. Dr. Chodos and the Dementia Care Aware team, they have our contact information. And so at any point, please feel free to reach out to us. And if we want to go to the next slide, if you do end up submitting, and we encourage you to submit for recognition, you would be in good company because we have close to 6,000 participant sites that have submitted their care description form. And so these are all areas of care, from hospitals, ambulatory practices, community care clinics, nursing home health, and we will be adding hospice to that as well. And we also have close to 3,000 of those sites, so almost half, that are committed to care excellence, which is that submitting of the level 2. And because people have submitted for level 2, we have an estimate of how many older adults we feel have been, or we believe have been impacted by age-friendly care or have received age-friendly care. And we can go to the next slide, which is 8.5 million older adults have been reached with 4Ms care. And we know that this is a very conservative estimate. We know that to be true. And we also know, like I mentioned earlier, that that age-friendly care affects more than just those that are receiving the care. This affects their caregivers, their children, their communities, and we're here to support you all as you hopefully join the age-friendly journey in the age-friendly space. I think that's the end of the content that we had. And so if people have any questions, we're here to answer those.
Yeah, I might take down the slides for a sec, unless anybody in the audience wants to, has a specific question. Congratulations. I mean, I think that is a really remarkable number. And I just want to let the participants today know that after this, we're going to talk about Dementia Care Aware specifically and spend time on the experience at Lifelong and Michael's experience, and then have time to really dig in there. But Kelly and Nicole may jump off. So just wanted to see if people have general questions about the age-friendly health system movement, the recognition process, things like that. So let's give it a second here. I don't see any questions at the moment. Just trying to see if anybody has any.
If not, that's okay. I put mine and Kelly's emails in the chat as well. So I know this is a large topic.
Yeah.
And I think it can be very daunting. So at any point, if there are any questions, please feel free to reach out to us.
Okay, and the general email, great. Age-friendly health system, AFHS. AHA.org, keeping it to the point there. That's great.
And I will remain on the line. I just won't be on video. So I'm just going to transition to phone. So if any questions come up, Anna, you can just make sure you say my name because I won't see if someone's raising a hand or anything. But I will absolutely be on the line until the end. So
okay, that sounds great. I decided to leave the slides up because of my technical difficulties earlier.
Thank you. All right,
Thank you both.
But I'll be there.
Thank you all.
Take care.
Thank you both so much. Okay, so we're going to move on, everybody, to a little more of a discussion about Dementia Care Aware in general. And one thing that, of course, we're if you don't know about Dementia Care Aware, this is the opportunity for us to just give you a brief introduction, but also just wanted to highlight how organizations, primary care clinics have, worked with us essentially and use the process of implementing Dementia Care Aware care pathways, and really the early detection emphasis of like a screening approach, how they've used that to go through age-friendly recognition. So, for example, if you look at the age-friendly recognition process, you'll see that an example assessment that they recommend, or they emphasize evidence-based assessments, as do we. So it would be screening with a mini cog, then assessing with a more in-depth cognitive test is one approach. And in our approach, we call it the cognitive health assessment. That was sort of a name given to us when we formed as an effort through our state's Medicaid program. Our cognitive health assessment does recommend using the mini cog as one option. We give people options, but also adding a functional screen and a caregiver. And then we encourage and help people think through how to do the next step in a workup. Other thing is we encourage early and often advanced care planning. So that's a good fit with the What Matters annual recommendation and aligning all care plans to care goals. We have additional training modules on that. And then for the medication management, they discussed the evidence base for screening for 8 high-risk drug classes. And we have a very similar emphasis, particularly with the focus on brain health, like how to review medications for their effects on cognitive functioning. And we give deprescribing guidance. So very, very strong overlap, and obviously would depend on, what you're working on and, how that aligns with clinic workflow and all that. As you'll see, like the real tough stuff is in implementation. Okay. I'm just briefly going to describe Dementia Care Aware so you kind of know what our approach is. If you don't already, we offer a ton of training. So a lot of what we do is like webinars like this or live trainings over Zoom, most often, sometimes in person if we get lucky. And we have a lot of online of the same material. So online modules you can do at your own pace. You can review everything we try to offer CE and CME. And we have some podcasts that go over this content. And then we do implementation coaching, which has sort of been one of our roles. Of course, the hard work is done by Michael and the folks on the ground. But we do consultation on how to implement a workflow, support with developing EHR tools, and do as much training and support as needed. And then we've developed and have opened a warm line where people can call with clinical management as they're in the midst of it. This works. And then we started really with an emphasis on the blue part of this, if you can see that color. And we've really expanded our clinical care pathway because we were really created with the mandate to focus on getting folks to understand the importance of early detection screening, however you want to frame it. But we realized, if you're really taking care of someone's brain, it's this whole, including what happens after with diagnosis and really coming up with a meaningful and achievable care plan, but then also the prevention aspect. How are we helping people prevent dementia? We have this big emphasis on brain health throughout adulthood, and that can help people who have dementia or prevent dementia. So what is the cognitive health assessment? What does the screen look like? We already sort of briefly mentioned the mini cog functional assessment. It's meant to be an annual screen that checks on cognition, function, and caregiver. It helps sort of direct our attention towards the right elements for doing diagnostic assessments if that's needed after the screen. And it emphasizes brain health. And all the tools involved could be done by someone who's not the lead clinician, the MD, NP, PA. But you can break it up among team members. And essentially, like most things the goal would be that it would be reviewed by a billing provider or a diagnostic provider at some point. So it's broken down into asking a brief history, like one question, or using screening tools that are validated, like a cognitive and functional screening tool, and we'll show you those in a sec. And then asking about if there's any care partner, caregiver, real brief, almost like for the cognitive and functional screen, same thing for the caregiver screen, just real brief. And this is what we teach and assist people with, is picking which tools you want to take out of the toolbox. And the idea is you want to screen for cognition and function. So those are the rows, and that there's validated tools for doing this with the patient themselves, which I think we're most used to, or with caregivers. And in the world of dementia, or a care partner or an informant, in the world of dementia, it's very normal and very routine and very appropriate to work with a informant or a caregiver on assessing the patient and how they're doing, in part because it's really practical. And but really it's a matter of necessity in the setting of dementia, because people often do not have insight into their symptoms or don't report accurately what they're going through because of the very condition we're looking for. So there's all of these tools that have been validated for functional impairment in the individual, cognitive impairment in the individual, but through an informant, which is why we provide these options. And all of these were picked because they have good, or the best data we can have on diverse populations, language, education background, cultural background, as well as their being short, which was a key inclusion criteria. We are all so busy. All right, let's move on. Okay, so that's the basis for what we kind of talk about and support people with and coach them with. So we really want to go to the case study. Michael, how ready are you? Good, okay.
I'm ready.
So, all right, I'm going to pass it to you and try to stay quiet over here, but thank you so much.
Oh yeah, thank you. Hi everyone. So I know I kind of gave a little introduction about myself. I'm a geriatrician that works at Lifelong, which is the federally qualified health center. So it's a collection of clinics, but I work at one called Over 60 Health Center, which is within Lifelong. But Lifelong has a bunch of different clinics, and our goal, part of my job is to kind of bring geriatrics and age friendly to different clinics. But I'll kind of give you how everything started. So I guess the biggest thing, I guess, is having someone who's geriatrics, focused. It doesn't have to be necessarily a geriatrician, but at Lifelong, there happened to be, this geriatric specialty medical director, and before that, a geriatric lead. So it was kind of someone that was a clinical partner in identifying programs for older adults in the organization. So I think that made a huge difference, obviously, in this first step, which is, getting leadership and commitment and identifying someone. And then, it became something where, the person that I was working with, which was more of a kind of a geriatric services person who had like a public health background, who was working at the organization, felt like age friendly was something that they were getting more involved in, and seeing other clinics doing, and we wanted a way to not only attract older adults to stay within a federally qualified health center, because that's an issue, right? Because we lose people once they start entering Medicare, they have a lot more choice in terms of who their providers can be, but also how to provide better, geriatric care across our organization. So that was kind of step two, assessing. We did a whole like needs assessment and figuring out what we needed to do for age-friendly workflows. And then, after doing actually a similar IHI like learning collaborative, we were actually part of one of these kind of groups. We applied, got level one recognition for age-friendly health centers in 2022, which is actually I mean, I feel like the level one thing is it's very low hanging fruit. Like I know that people it really is easy to do. I mean, you could see that there's a drop off from level one to level two just because collecting data is always harder. But I feel like it really does help, you know, they talked about the 8 million patients that are being reached out to, but I think it's even more, probably the number of providers is even more important because I think we're learning as a system who are caring for older adults, like that's where I think it really makes a huge difference too, because all of our providers are kind of getting that in the water and understanding that that's something that's important before when it wasn't, it wasn't part of our even what we should be doing with older adults. So I think that even level one makes a big difference with how everyone in our clinic works. Anyway, but then we did like Epic, kind of figuring out within our build of Epic, everyone has a different build of some EHR, um, how to do documentation and screening with an MA, medical assistant, and a provider kind of dyad. So the medical assistant would do most of the screening, and then, then the provider would follow up the screenings. And then we got data, and then, once you get data, you could apply for level two. And again, the level two, just so you know, I mean, I know probably people got this, but you just need to provide the data. You don't have to like hit a benchmark necessarily. It's more just like that you're collecting the data and actively, because you're collecting the data, you're hoping that it's going to get better. But, there were some times where we've stuck with the data for a few months and it was like getting the old age friendly kit was very low. But then as time went on, and maybe our fall risk screening was really high because we were doing that already, mobility, but then it took a while to kind of get the whole kit going. And still, that number is still not as high as some of the cognitive and fall risk screening alone. So we're still working on trying to get the whole age-friendly kit done for every patient every year. And then we partnered with Dementia Care Aware because we realized that like the cognitive screening is what most of our providers felt like was the hardest to kind of follow up on, and kind of we had the weakest, workflow for. And it was just something that was really a nice collaboration that we can be able to provide support with. Just, they're doing like education, but then also like on the ground support in terms of our workflows and trying to help us drive our workflows kind of aligned with this cognitive health assessment. And yeah, we actually have another clinic that's not on here, called East Oakland, which is a different clinic within Lifelong that got level one recognition, I think last year. So at end of 2025, I think was it. And there we're working on trying to collect data to get them level two. But, eventually our goal is to have multiple clinics, within our system because we have around 10 clinics. And then some smaller, supportive housing sites and street medicine teams. So, I mean, kind of hoping that eventually it'll filter into all those. So, but that's kind of an overview of where we're at.
You explained it really well, and I think brought us along on your journey and kind of helped us appreciate how long it's, how it takes a while. And even amidst a lot of change, like putting more change on top of that can be challenging. So it sounds like you just keep building the momentum, which is really cool. So we kind of talked about the journey. I don't know if there's anything else. We came up with some discussion questions. So for the audience, if this is kind of ringing some bells about the work that you're doing right now in the action community, the project that you've chosen, maybe one thing, Michael, is to give a little more sense of like the training. And I really appreciated what you said about like, obviously our focus is the patient and older adults and how it reaches and makes our care. But there's a really great emphasis here as well. Like a really important piece of this is the providers. So all the different M's, yeah. What does training look like? How do you squeeze it in? All that kind of.
I mean, yeah, it definitely, and I think that I could share eventually my email and stuff when people want more granular detail, because I feel like that's what helped us the most is that all these things are kind of like sounds really great, and then when you try to put it into clinical practice, it's actually very difficult, and like who does what and how that actually folds into like a 15 to 20-minute visit is not the same as like writing it down on the IHI like submission for, level one. So I think that it was really important to kind of develop, well, first of all, not having someone else that was in the organization that was, helping me with us more on the clinical side. So like for instance, for our trainings, we had to train providers, kind of make them feel comfortable in terms of like most of them had some background, because we're at an over 60 clinic, that these things are important, but kind of helping support them dealing with positive screens in an already busy clinic schedule. So we had, provider trainings. We ended up having, we have provider meetings that we had, an hour discussion with just me, but then eventually Dementia Care Aware, helping kind of work through some of these workflows. So what to do with the positive, how to work with the what matters questions, what to do with the positive fall screen, what to do with the positive cognitive screen, and then kind of going over the medication review. But it always ends up being talking more about cognitive stuff, I feel like. And then the second thing is that, we needed the medical assistants to understand, like, obviously this is more work for them. How can they do this workflow within a busy clinic schedule? We train them on how to do mini cogs. That some of that was with actually Alzheimer's Association did some trainings with us, and then we also had our own online modules that we developed for the medical assistants, which I think was really good to not have trainings be just in-person trainings, but have some sort of online way to do it just because there's so much turnover, in community health clinics. So I think like having some trainings that are just there so that if like half of the staff are not there anymore, it's not like, I mean, there's someone maybe there that could teach them, but that there's some trainings that they can do that kind of gets them up to speed so that it's not depending on one person providing these trainings. It's just, it lives somewhere else. So we had medical assistants trained on how to do, fall risk screening, which was pretty straightforward for them. But the biggest thing was kind of like the mini cog was the big thing that they kind of was a new, skill set, I think. And I think that it really worked out well for us. I know initially I've told other organizations that, we had medical assistants doing mini cogs, and they're all like, they can't do mini cogs. And, that's not something that is within their scope. But, at our clinic, it really does work well. And I feel like we're, getting good information. So just to throw out that everyone does it differently and has different opinions on which parts of their clinical staff can do these things. But I think, trying to find out who can, do it other than just provider time.
I know, like, where I work as well, like that it's come up. It's not, nobody feels it's feasible for the medical assistant to do it. And so that's something we're still kind of chipping away at, if you will, just to see. I think other parts of the care gaps that they track and the, routine annual or, vaccine schedule type stuff is going to be more automated and like patient facing. So it might not take as much of their time. So we'll see if there are other openings, but your success in that area and over 60 success in that area has really been instructive to me, because where I work, it kind of exactly as you were alluding to, it's like an option, even though in Dementia Care Aware, we've, in addition to your example, we've seen, and we know that the evidence would suggest, or like the way the tool was a non, a non-nurse, a non-doctor is totally an option to do it. We've actually trained community members like social service and community organization providers to members just to do it. They've done like brain health events and things.
Cool.
So I don't know if this resonates with other people's experience. So where are you guys now in the dementia care pathway. And I
Well,
know one of the things we tripped on was like, what do we do now? If once we have this screen.
yeah, and I think that again, that goes back to figuring out who, I mean, one thing that we're working on now that's kind of in the really early stages is, for a positive screen, oftentimes what happens is we get a mini cog that's positive. The provider feels kind of comfortable starting this kind of elements of the brain health plan. Like, we have I didn't talk about the provider training, but part of it is offering, a dot phrase, which is just, something that is within Epic where you could, pull in like a list of possible follow-up steps. So we find that just kind of as provider training to kind of get people used to like what are the possible steps for a positive screen. But I felt personally the thing that I always trip on is that like it's hard to have time to do a full cognitive screening, and I think that parts of the I don't know how much of the dementia care cognitive health assessment has been brought up. I know you brought it up just now, but like the finding out the functional status and the care partner is not something that we're doing consistently. So like those all the steps of the cognitive health assessment were kind of like not happening consistently. So and we say like we're going to bring them back for a mocha next time, and then they come back because the next appointment's in 6 months anyway, and then they have another thing that came up, obviously, because they weren't able to be seen for that long. So it's hard to squeeze in, and oftentimes as a provider, even I'm dreading like needing to do that mocha because I know that it's going to make my schedules are screwed up, or I'm going to have to ignore some current complaint to do it because it just takes long enough, 10 to 15 minutes of a appointment that's long that's it. So we're trying to do it so that, there's a positive screen and then they could refer to someone to do a MOCA. In our system, and it ended up being the behavioral health social worker that had the most availability to do this, which is interesting, but that's who ended up being able to do it, not a nurse. And because we went through like, oh, should a nurse be doing it? Should be another provider who's kind of doing this regularly, but it ended up being that we happen to have, a behavioral health team that was willing to do that, and that they maybe might be able to collect some of the initial data for functional status and a health partner so that they could come back to another visit with all this information, and the visit could then be targeted towards reviewing that information so that you have the whole kind of cognitive health assessment kit done really outside of your visit. You know what I mean? And the visit could be really done reviewing what the data is, right? And that you could focus maybe more on the nuances of, where we need to provide care, which is, safety concerns, behavioral issues, caregiving, the stuff that, I feel like families actually care about so that we're not like spending all of our time just doing mochas and then having 2 minutes like, oh yeah, it's positive. You probably have some sort of dementia, or because I feel like that's kind of like how it is that if you want to like people want to answer during their visit that you do the mocha or at least some preliminary assessment of it. And if you spent the whole visit doing the mocha, it's a little tough. Like I've had that before where it's like a little tough to kind of like analyze, give all that stuff without having another visit. So we're trying to mix and match how we do that. And maybe everyone's clinic is not able to do that, but I think that that's the way that it feels easier to offload because providers don't want more work. They want to feel like there's like less work to them. And I think that even though overall this is more work because you're getting all these positive screens, it feels better to the provider that now they're offloading some of it. And I feel like it's been more well received, you know. Um, and again, as it becomes part of like just your workflow and like it's something that is important, even someone in your organization being part of these learning, collaboratives, I think really matters because then it gets them kind of, I don't know, indoctrinated, I guess, or just kind of like figuring out like this is something that's important for older adults and it's not something that like one person is just making up like me. I always think that like that's why I appreciate like the collaboration with Dementia Care Aware and then initially doing this IHI learning collaborative because it really lends a lot of validity, I think, to what we're trying to do, which is more work. That's not like they're just kind of like, is it a HEDIS, is it a quality measure? Is it a HEDIS make? Well, why are we doing this? And I think that it lends a lot of credence and validity when you have these, people who aren't in the kind of bathing in this to like see how important it is. So I think finding someone from an organization who you might not normally think that might be, on the ground doing this, just part of these talks or part of a one time coming to one of these sessions actually helps a lot because then they understand, oh, okay, that's why this stuff is important versus kind of you trying to give them the elevator pitch. So, um,
Oh my
yeah.
gosh, you said so much that was so rich and awesome. And I'm so grateful, like you're sharing your experience because, okay, like things I heard, um, primary care is not interested in being like mocha special. They don't want ask me about what a mocha is buttons. They're totally fine to pass it off because what they care about is doing the caring and the care planning and providing support and meaningful next steps for patients. And like, that's not like we're doing when we're doing the mochas and then at the same time having to ignore the actual issues. So for if anybody is doing, again, I imagine you are like a mentation focused or a dementia focused program for this action community. Um, I think it really, if this is what you're going through, it's just super common. Like this is probably one of the biggest barriers we hear about again and again is like taking the next steps in the diagnostic, the cognitive testing being one of those things, and the overwhelm at having to do it. And at the end of the day, if somebody's really struggling cognitively, it can easily take 30 minutes, so to get some sort of, what we're supposed to do done. One thing I'll plug for Dementia Care Aware is we try to upfront a lot of like the brain health and care planning pieces because you can do so much of that outside of wherever you are in the diagnostic pathway, if you will. So again, to emphasize like how important it is that we're still able to care for people while we're in this like diagnostic limbo, or we have stuff to do. Like this is an active and I'm not saying that because I'm trying to rebrand a little bit. I am, but like it is actually the case. Anyway, it's just really, I really like really dinged when you were talking about that like this is why we all go into healthcare or in the business of such as it is of helping people, which is like that's the fun stuff, that enjoyable stuff, not all the necessarily the diagnostic pieces, which are, again, we know are important, but it doesn't mean we have to do it. So you guys came up with a really creative solution. I wonder if anybody else in the community has thoughts about making that work. But I think you did such a good job of thinking about how, you found the part of your team that would be well suited, had the time, started to work on it. It's working out great. Partners are super grateful. Do you have a sense of like, was this something that ramped up slowly, or do you feel like everybody, one thing you didn't mention is if you have a sense of how often people are positive and need those next steps, if that's been a big challenge and a big burden. And I will say, you mentioned as a side note, too, that you guys sort of customized, meaning you really focused on the mini cog, which is what IHI recommends as well. And Dementia Care Aware or cognitive health assessment kind of approach tries to keep the cognitive functional caregiver stuff together, but that a lot of places can't make that happen. And that's totally, this is real world. So what's possible is possible. But yeah, go ahead. How's that been going?
We definitely weren't able to keep all that together, like you said. Yeah, I don't know. I mean, I just feel like that every place is just so different. It's hard to give like anything prescriptive. I don't, it's just like it depends on where you are. And I mean, right now I feel like it took so long, like you're saying, like you're asking about the time course of all this, and it could take like, I mean, obviously it took years to figure, for this to kind of start happening. And even now, I'm not like pretending like this is like happening with every single patient consistently every single time. We're still working on that, and I think that just we're trying to make it so that these workflows are available for people, and that once they start getting used enough, it becomes just that's what you do. You know what I mean? Versus kind of these pilots that kind of stutter and stop, So we're hoping that, right now, I don't think that we're having enough positives that at least that, I don't have the numbers right now, but just in terms of like, it's not like overloading anyone right
Hmm.
now, but also it's not happening for everyone. Like we actually give it part of our discretion to the medical assistants to not screen certain people with the age-friendly questions if they feel like that's not doable within their work with their appointment, right? So we actually kind of give some power to the medical assistants that they're not feeling like this is something where they're burdened. They're allowed to delay the care. We have a care gap that kind of triggers it. Within a care gap is kind of like a reminder in Epic, of like when people's vaccines
Hmm.
are due, there's one that's fall risk prevention that just is there. So we use that as a tie to do the age-friendly screenings. And we allow them to delay it because, and what I'm telling providers is like working on maybe identifying one patient per half day that you're going to be doing this with. So
Hmm.
I think that that's like a lot easier for people because then, if everyone was due that afternoon, the MA would just be going insane. I mean, doing all these screenings for everyone when they're just trying to room people and get vaccines and do EKGs and all the stuff that they're supposed to do, which is a lot. So we allow a little bit of discretion because we know it's not a quality measure at this point at our clinic. We don't want for them to not get a depression screen or a vaccine or a colonoscopy that is due because their medical assistant was feeling so overburdened doing these age-friendly
Hmm.
screenings. You know what I mean? I mean, honestly, that's because that's the bottom line of our clinic and the bottom line of our, funding and everything. It's not worth sacrificing that. So we want to make sure that we're giving people some flexibility and want it to be done in a way that's actually valuable too, right? I mean, if a medical assistant feels rushed and a provider feels rushed to do these things, it's not going to feel great either, you know.
Hmm.
I mean, you can imagine going to your own clinics, sometimes you fill out these things online and then the provider never discusses it. I don't know if you've ever had that
Oh
experience,
yeah.
but like it's like, okay, well, why did I do that? You know what I mean? Like, what's the point of me bringing up these
Point.
concerns if they're not being addressed, in a good way? It just feels like, you know, so I feel like that's important to acknowledge. Yeah.
Absolutely. And also, you make it, as you were saying that, I was thinking, oh, and like nobody's had this screen. So probably everybody's due. That would be,
Yeah, that's true too.
if
Yeah,
you're at an
no,
over
everybody, yeah,
60s
right now,
clinic,
yeah,
then it's like it really, so it makes sense that you might have some way of like step rollout.
yeah.
I will, just for the sake of conversation, somebody did put in the chat, like what data points are you submitting, like for
Oh,
the age friendly recognition?
well, right now we're just doing, fall risk screening if it's occurring. So we're just doing the steady questions, the what matters most. We do two separate what matters most questions that are asked in inputted free form, and then mini cogs that are due. And then for medications, I mean, we're kind of a little bit I mean, to be honest, a little bit half-assed to me, because we're still working on kind of like Epic keeps promising that there's going to be some easier way of doing this because it's very hard to do high risk medications, review. But we just have it that the medications are reviewed by a provider during the visit for high risk medications. Like they self-attest that. So that was enough for the IHI workflow, but I feel like we could do better with that. You know what I mean? But those are the data measures that are being submitted for all
Thank you
four.
for sharing that.
Yeah.
And just say like maybe as you're thinking about adding this part, because you guys done so much work already in different M's, and adding the cognitive M, you've shared already a lot of fermentation M. You've shared a lot already about successes, barriers, challenges. Also, I want to highlight the success you mentioned about just the little shift in culture change, exposure to the bigger movement, like helping people feel like this is, see the value basically. Really awesome. But any other challenge? I just wanted to see if you wanted to just share, one more challenge or like what you feel like you hear the most is the biggest challenge.
I think I've talked about most of the stuff with the screening at least, and you know, people worried about time and how are we going to do the positive. But I think that what you said it kind of helps reduce all that and refocusing people that this is not like you said, it's not like even though the name is Dementia Care Aware, the goal is like brain health for everyone kind of a thing. You know what I mean? And I think
Mm-hmm.
that is important to like, tell providers like, yes, you want to address safety issues, and if there's obviously, always everyone says like, okay, if this is like a rapid progression, maybe they have something medical going on. Okay, we get those things, but really, this is you could give time for this. I don't think that you need to. The goal is to not do that MOCA and then diagnose someone in a 15-minute visit. Take 15 minutes to do the MOCA and 1 minute to diagnose them. Like the goal is to like have a
Hmm.
workflow so that people feel like they're getting all these things done eventually, and that eventually that if they do have dementia, that we're catching that earlier on, and if not, that I think that we know that there's a lot of people that fall into this mild cognitive impairment range that never progress, and the thing is that we have time to help these people and maybe address all these risk factors that might help them stay in that range. So yeah, I mean, I think that time, just like letting providers know that the point of this is time. Like, don't feel like just because you have a positive screen, people feel this like urge to like, well, how am I going to diagnose them as soon as possible if they're positive? It's like that's not the goal of it. Um, so yeah, I don't know. I feel like that kind of helps with
Yeah.
like training them to be time, like that's okay to do time. I mean, there's a bunch of other challenges, but that's like I was going to go into like, I mean, dementia behaviors and things like that. That's like what
Yeah.
people
Yeah.
actually end up bringing up as their problems that they're actually challenged with. But I feel like in terms of the
Mm,
screening thing, I feel like it's like letting people know that there's time, and like how I kind of address these gray areas, right? They're always like worried about when can they diagnose them? Can they drive? What about the behaviors, and like do I need to worry now or manage it later? So those things help, those are some barriers, I guess, that often come up or challenges.
oh, it
But
was
they're
so
normal.
good.
Yeah.
So we have a really, really good question, which is just how often
Refusing.
is the screen refused?
I don't have the numbers on that.
Yeah.
I
Do
mean,
you have a sense? I actually pretty infrequently.
yeah.
It sort of depends on how you present it, but maybe.
Yeah, I feel like most people, when we bill it as something that we're just doing for everyone, and it kind of is part of this toolkit rather than like, oh, we're worried about you and singling you out, I think that helps compliance with the screen. But
Hmm.
yeah, I don't know the data for that. Yeah, I don't know.
And
That
and
is
the
curious. I mean, how do you deal with that? I mean, I think it's just going to be a number that you accept and then kind of hopefully are able to do. I mean, we didn't bring this is not part of our workflow, but I mean, there is like the 88 can be done for surrogates too, and having a care partner do the screening. So, I mean, technically they could screen positive without ever having done any cognitive
hmm
screening, at least to kind of put them on your radar. Now, obviously, that person's not going to comply with, if they don't want to do the screening, they're probably not going to do the MOCA and they're probably not going to do a lot of things, but I think some of this data, you just give it time to kind of play out, and you could collect the data as you can, getting collateral information. But you're right, I guess that would not qualify maybe for these quality measure.
hmm
We're working with a DSNP
Or
program
you
right
could,
now, so I don't really know. We haven't talked about this at all, so I'm not sure that's a good
yeah.
question for who asked that.
Or you can take them. It sounds like you can take them out of the denominator if they, if that's an acceptable reason to, it's like not appropriate for screening, like they're not for the inclusion group. Um, it's interesting though. I mean, I will certainly in more like, and everybody should, I hopefully can see that I put up our information if you want to claim CE, and you'll get that in an email as well if you registered. Um, but on the issue specifically, I guess we'll end with these couple things. One, it's remarkable all that you've done to get level 2 recognition, and just be so persistent, kind of adding these different M's. I think it's an incredible example and shows how helpful the IHI framework is and how like doable it is as long as we have committed champions like you. So it's really amazing. I think the other thing is for the dementia thing, how flexible, like how, you guys also were a really great example of just reaching out to organizations in your area to help fill the need of training, of, workflow customization, getting advice on how to do things. So you partnered with us, partnered with Alzheimer's Association. I'm sure there are more. And I just really wanted to highlight, yeah, having champions is key. Kelly said, yeah. And Michael, you're one of the one of the best. And that's really clear with all that you guys have accomplished. Just sort of, I think there were so many little lessons in there about how, yes, we emphasize this, we make it part of the culture that we do this kind of care for older adults, but that we're also really focused on how we're doing this as a team to make it sustainable and also make everybody on the team do the things that they feel is, their role or they could do or they can contribute. And then it sounds like that's making it a lot more sustainable for you guys. So we're just so lucky to one, have this partnership, but also to have you be willing to spend this time sharing your experience at Lifelong. Thank you so much, Michael.
Thank you. Yeah, no, thank you for the kind words and all the support that you guys have given us. I mean, so yeah. And please, let anyone reach out about, again, the nitty-gritty stuff is always the hardest. So if it's like the smart phrase that we use or what it looks like in our EHR for the rooming. I mean, I didn't share all that stuff just because it might not be applicable to everyone and everyone needs to look at their own system. But if anyone needs that, just reach out.
Thanks to everybody in the community who came out today. Really amazing to have this chance to share these examples and these resources. So do reach out if we can be helpful. And thank you, Michael. Right. Thank you, Kelly.
Thank you, guys.
Thanks, Nicole. Take care, everyone.
All right. Bye.